Hi everyone, sorry we couldn't have class tonight. This is Dr. Stoltzfus. Since we couldn't meet in person, I thought I'd record my lecture for our unit on assessment. We'll follow up with this next week in class, but wanted to just at least go through some of the content. Please don't watch this video until you have a chance to do the two case studies that I put online on the Moodle site, because I'm going to refer back to them in this video, so it's not going to make as much sense if you haven't seen those yet. Okay, so really just wanted to talk a little bit about the assessment process and maybe some issues we might run into with assessment. So starting off, a lot of times the first part of the assessment process is what we call screening. And screening is sort of separate from assessment. A lot of times screening is a very brief session where we just try to get a handle on whether somebody has a substance abuse problem or not. Excuse me. One of the places I used to work when I worked in an outpatient clinic, we would do screenings for free. And so if somebody was worried about their drinking, or more commonly, if someone's boss or spouse was worried about their drinking, and they called in, sometimes what we do is we say, why don't you come in and see us for a 15 to 20-minute assessment. We'll get a brief overview of what's going on with you, and we'll make some recommendations about whether you need a full diagnostic assessment or not. And I'll explain more about the diagnostic assessment process in a minute. But so these screenings they're usually really brief. Sometimes they're in a formal treatment setting. Other times this might even occur in like a medical setting. You know, somebody comes into an ER. We watched the video a few weeks ago on the first night of class about the Saturday night in a Dallas ER where the doctors showed people, in some ways they were sort of doing an assessment of whether somebody has a drug problem or not. And then one guy, remember, they were going to refer him for treatment. So anyway, that's sort of what we're talking about with an assessment. One of the things that we often do in assessment is we sometimes use these rapid assessment instruments. So you might hear these called RAIs. And I won't say a lot about these because your book actually has quite a lot of information about them, but I'll just mention a few of the more common ones. A CAGE is a really easy one to use, and this one's really more related to alcoholism than other drug abuse. But what you ask in the CAGE screening assessment is you ask if the person's ever tried to cut down on the drinking. And the reason we ask that is most of us who don't have a problem with drinking, we don't try to cut down on it. So if somebody has been at a point where they feel like, I need to try to cut down, even if they're not trying to cut down now, if they've had that feeling at some point in the past and they've acted on it, it's not a sure thing, but we're starting to think, well, maybe they'd have a problem with this, or maybe there's somebody who at least we need to look further at whether they have a problem or not. The joke I'd sometimes make with clients is, if we're talking about peanut butter and jelly sandwiches or something like that, you're not really trying to cut down on that. Things that are harmless, that we're not concerned about, we don't try to cut down on. So if the person is trying to cut down, usually we have a sense that they are starting to be aware on some level that maybe they have an issue. Secondly, we want to find out if they've been annoyed by other people criticizing them for their drinking. And so if you're being nagged by a spouse, or if a boss is asking you to quit, or if they're kind of criticizing you thinking you drink too much, your buddies you're annoyed that you're always the one that gets drunk when you go out, that would be the kind of thing we're looking for there. We want to ask the G in the CAGE. We want to ask if they've ever had guilty or bad feelings. And again, things that aren't problems, we don't usually feel guilty or bad about. So if somebody's felt that way, it can be a little bit of an indication there might be an issue. And then finally, the last one, the eye opener, that's when we ask them if they've ever had a drink first thing in the morning to kind of get themselves started. And that actually is even starting to be a little bit symptomatic, or it can be, of withdrawal. Sometimes people who have been drinking for a while or in the later stages of alcoholism, they can actually have a hard time being functional without alcohol in their system. I'll never forget, probably the most extreme case of this I ever ran into was a woman in her mid-60s when I worked with her. She was in the group therapy session I ran. And she told us that she could not make it, could hardly walk in the morning without alcohol. And so she would sort of drag herself to the bar, and she felt too weak to even hold her drink. And so the bartender, first thing in the morning, would put a straw in the drink for her. And then when she had a drink in her, she was usually good to go, and she was feeling more normal. So you put that together, the C in cut down, A for annoyed, G in guilty, and E in eye opener, and you get CAGE, which is the acronym we use to remember that. Some of the other more formal tests, the Michigan Alcoholism Screening Test, or the MAST. This is sort of a classic. I have a copy of that I was going to hand out in class. So if you'll just remind me, I'll give you a copy of that next week when we meet. Drug Abuse Screening Test, or DAST. Problem-Oriented Screening Instrument for Teenagers, or POSIT. Substance Abuse Subtle Screening Inventory, or SASI, And then there's also the McAndrew alcoholism scale. So these are other instruments that you can use that you can give to somebody. They can take them in a few minutes, and it doesn't take real long, and you can get a sense pretty quickly of, does this person have a problem or not? So it doesn't give us a whole diagnosis, but it lets us know, yeah, is this somebody we need to look further at? So for people that go through that screening process, or for people that we just kind of know, maybe based on their history that they're likely to have a diagnosable condition, or if the consequences that they've had are severe enough that we just might need to move right to the assessment. We don't always do that screening, but sometimes for a variety of reasons, whether it's a medical setting or whether the person's kind of tentative about entering treatment, sometimes we start off with a screening. If we're doing a full diagnostic assessment, when I used to do these, it was usually 1 to 2 hours, and some of the payers, and I forget which one was which, but some of the payers would do 1.5 hour sessions, others would do 2 hour sessions, and that was just for the very first time we met the client. So normally we couldn't bill more than an hour with them, but the first time we met, because there was kind of an acknowledgement that we needed more time to really get a handle of what was going on. We could have a longer time to do the diagnostic assessment. And for what it's worth, this was also the case when I did mental health work, that they would give us a longer session to diagnose people, just because there's a sense that there's so much stuff we have to ask, so much information we have to gather, that we need to have more time. The other thing that the assessment usually includes is a social history. So we're gathering a lot of information, and then we're using that to make the diagnosis. And I'll talk in a minute about some of the different things we want to ask the client about. We are also assessing, and I'll also talk more about this in a minute, but we're assessing for comorbid mental health conditions. And so it's very, very common for somebody who has an alcohol problem to also be clinically depressed or to have anxiety problems. Personality disorders aren't uncommon, although they're hard to tell because a lot of times people who are actively in an addiction, that affects their personality. They can be very rigid. They can be sort of antisocial. And so sometimes it's really hard to tell what's going on in terms of personality until the person achieves some sobriety and kind of settles down a little bit. So thinking about social history and the kind of questions we want to ask people, a lot of times I like to start off with innocuous questions that didn't put people on the defensive. So I'd ask about their education level. I'd ask about their employment history. And this can be helpful because, sometimes we find out that they went to college, in terms of educational level. Sometimes that leads into a conversation about, oh, yeah, I started drinking with my buddies in college. Or it's just helpful to know that, sometimes in our culture, we have this stereotype of alcoholics and drug-addicted people as being people that are the Skid Row alcoholic, right? The person who has no education, the person who, really hasn't gotten very far in life. That's not always true. I've treated doctors. I've treated people who were successful in business. The sorts of places I worked, that wasn't as common. And actually, when I say I treated a doctor, I think actually I treated the son of somebody who had a doctorate in education. But the person with the doctorate was coming for therapy because his son had a problem. And so, this was a very well-to-do family. The person had actually been my elementary school principal, believe it or not. And so, here we're coming to meet with him to do family therapy for his son who had an addiction issue. And so this is not something, as it's not something that discriminates on the basis of education or job or that sort of thing. So it is good just to kind of know where the client's coming from. And again, sometimes, we hear about substance abuse either starting during a certain educational period, or sometimes it's affected their education. Sometimes they haven't done well in school because they've been high all the time. Similarly, it's really good to know about their employment, whether they're employed now, what their employment history has looked like, whether they've served in the military, that sort of thing. Just that sort of background information that we collect for everyone. Medical is really important, medical information. If the person's been drinking or using drugs long enough, there may be medical complications, and whether that's cirrhosis of the liver, whether that's lung issues, that they're smoking marijuana, there are just all kinds of medical issues associated with substance use. And that was in one of the chapters we read for last week, the physiological result. And so sometimes if the person has certain medical disorders, that's going to affect their treatment. It might affect their ability to even stop drinking. We might need to think about detox. if they're reporting things like delirium tremens for alcohol users. Excuse me. And then we start, once I've asked a few of the easier, more innocuous questions, I usually start asking about, their drinking and drug use history. And I should say, and hopefully you went over this in one of the classes last semester, but I usually start off with a pretty open-ended question. Before I get into any of these social history questions, I usually just start off with something like, what brought you here today? What can I do for you? And a lot of times there you get a story about, my boss told me they're going to fire me if I don't come in, or I was in jail, I'm out on parole, and a condition of my parole is that I go to substance abuse treatment, that I get an assessment and then follow the recommendations. And so a lot of times we start off with that and then kind of move into some of the less difficult questions. And then as we go on, I like to sort of ask some of the more probing questions, but I don't start off with those right away because that kind of makes people defensive. So when I start gathering the drinking and the drug use history, some of the things we often ask about would be age of first use. And it's not uncommon for people who have a substance abuse problem to start at 9, 10, 11 years old. Ask about the quantity and the frequency. So how much are they using when they use, and how often are those episodes? And so it's different if somebody binge drinks, but they only do it once a month at a college party. That it's not that that's safe. It's not that we don't want to treat that, but that's different than somebody that's drinking every night, doing binge drinking every night. We want to ask about the consequences, and there's actually sort of some reality testing here. Does the person recognize that their drinking or drug use has caused any consequences, any problems in their life? Some people do. Other people will tell you this horrible tale of woe, but they don't link it into the substances. And, that's a lot of times we can kind of see what's going on, but maybe they're not ready to admit it. We also want to ask about their family history. As we talked about in an earlier class, we know that there's some degree of heritability in substance abuse problems. And so it's good to know whether other folks in their family have had these issues. We also want to know about their past treatment experiences. And I think I mentioned somewhere, the last time I saw the statistic, it's something like 8 times in rehab or 8 times in treatment before people actually establish a pretty serious amount of time in sobriety or in recovery. So it's good to know whether they've had treatment experience or not. The other reason that's good to know is some people are very experienced in treatment. They can talk the jargon. They sound like a staff member, but sometimes they just haven't internalized it yet. So they might know a lot. They might be able to talk about the 12 steps and about recovery and relapse prevention, but they might not really. Sometimes that can sort of be a smokescreen as a way of not really getting into their stuff. They kind of talk more about treatment from sort of a distance, from a psychological, intellectual perspective. As I mentioned before, a high rate of comorbidity in terms of psychological issues along with substance abuse. So we want to ask about their history. Have they been diagnosed with a mental health disorder? Has anybody else in their family been diagnosed? Have they been in treatment for that? We also want to go through and ask about, are they having any symptoms? Even if they've never been diagnosed, are they feeling sad a lot? We just want to ask about their mood, about their coping skills, that sort of thing related to psychological issues. We want to find out if they've had any legal involvement. Are they on probation or parole? Do they have a probation officer they report to? Have they been arrested? Are they there for DUI? One of the things I should mention is a lot of the diagnostic assessments I did were people who got stopped for driving under the influence. And a lot of times, besides a fine and losing your license and that sort of thing, the court requires you to get a substance abuse assessment. And so that was often, when I asked people why they were there, that was often a reason that got them in the door. And then I had to decide, is this a person who, it's New Year's Eve, they were out with their friends, they made a bad decision, and maybe this is the only time in their life they've ever done this, they just happen to get caught? Or is this kind of, a repeated issue and something that's likely to recur again? And that's not always an easy decision to make. We want to ask about family and current relationships. Who do they live with? Sometimes the living situations are very interesting. Sometimes they're living with people because they don't have any place else to go. They're living with distant relatives or friends. Sometimes there's either a live-in paramour, a boyfriend or girlfriend who has children, but they're not that person's children. And so just getting a handle on kind of what their family situation is and other close relationships as well, friends, extended family, that sort of thing. It's usually really good to ask about relational and sexual history, and these can be awkward questions. But a lot of times now we're asking about sexual orientation, we're asking about sexual behavior, and we want to be careful. If somebody's very uncomfortable with this, we don't want to just force these questions. But the clients who come in with substance abuse issues often have been acting out sexually, and so it's not uncommon for people to have been with multiple people. They may need to talk to a spouse or significant other about that. So in the case study that you all are reading for tonight, Hope, the person in the case study, we don't know what she's done, but her husband saw her in broad daylight kissing another man. That's the kind of thing that's not uncommon. People who are drinking heavily, using drugs a lot, they're often in multiple relationships, or they've often had multiple partners, and there's high risk associated with that. And then if they're also, injecting IV drug users, that's also a risk that, we want to know about that can be, passed sexually. So it's good to have a handle on that, even though those can be awkward questions to ask. We also want to ask about religion and spirituality, and the practice now is we should ask about that usually no matter what. Even the Joint Commission on Hospital Accreditation requires us to ask a question or two about that whenever we're admitting somebody to a medical facility. The other reason we want to ask about it in substance abuse treatment is so much of substance abuse treatment relies in some way or another on Alcoholics Anonymous, the 12 steps. And the 12 steps do draw on religion and spirituality. They talk about finding a higher power, turning your life over to the higher power. And so somebody who says, oh, I'm an atheist, I don't believe in a higher power, we'd want to know that. We might go a little bit easier on the 12-step thing with them. We might try to find some other ways for them to get social support, because that just may not work for them. Okay, and then, once we've collected all this information, then we want to assign a diagnosis, and obviously we use the DSM-5 for that. You all have been trained in that with Dr. Copeland last semester. And I know we've talked about this already, but just to note that this has recently changed. So until a couple years ago, when we were still under the DSM-4 and then the DSM-4-TR, we talked about substance dependence or substance abuse. Now we've just made it all substance use disorders, and there's a range of mild, moderate, and severe, and so we code it that way. Rather than having one kind of less severe and one more severe disorder, it's now more on a spectrum. The other thing I wanted to mention, I don't know if you all have run into this at all or not, but the ICD-9, which is the International Classification of Disease manual or process that's put out by the World Health Organization. This is also used. I've seen it more used internationally, but I do know that there's sort of another classification system that I've seen. Your book actually has a comparison between the DSM-4-TR and the ICD-9. There's a lot of similarities, a little bit of differences, but if you run into that, that's what that is. The other reason that comes up is a lot of the coding that we have to do to get paid for our services is actually ICD-9 coding. And so a lot of times we have to find the diagnosis and code it with an ICD-9 code. Or I'm sorry, it's now ICD-10. When I was practicing, it was the ICD-9. Another thing that often comes up at the assessment phase is confidentiality. And you saw this in the case study tonight, where we got one story from the client. We needed to talk to some other folks to kind of get more information. We can't do that without a release of information form. Sometimes we call these consent forms. But sometimes, as you saw in the case study night, sometimes there's self-determination issues for clients who are mandated to substance abuse treatment. So the sad truth is, as much as I wish I would have had clients just walking in off the street saying, Dr. Stoltzfus, can you please help me get off of drugs? I really want to be clean. That very rarely happened. More often than not, it was somebody coming in saying, well, I'm here because I'm going to go back to jail. Or I'm here because my wife's about to kick me out, or my husband's about to kick me out if I don't get help. And so then a lot of times we don't get a true story from that person, or we don't get the whole story, or we at least want to hear from other people who are important in their life. And especially if they're a mandated client, we usually have to send a report to the probation officer or the judge or whomever saying that the person's in treatment, that we've diagnosed them, that they need treatment. And then that officer or the court makes sure that the person's coming for treatment. And so in order to make those reports, we need to have the consent form signed. But to me, that never felt like a completely clean process, because a lot of times the person would rather you didn't share their stuff with somebody else, but there's going to be a consequence if they don't sign that form. And so it's kind of the compromise we had to make in substance abuse treatment, where we had to kind of say, hey, we know that we'd like to have self-determination for our clients in terms of them deciding who we release information to and who we don't. But if the client wants to stay out of jail, they really don't have much of a choice, and I'm kind of a part of that process. So whenever possible, I tried to talk to clients, talk them through that, explain if they didn't want me to talk to their probation officer, I legally couldn't, but then I couldn't guarantee that the probation officer wasn't going to send them back to jail. And so it was just kind of a situation where I had to process through that with the person. Whenever possible, too, I try to have the client, if there's something bad that needed to be disclosed to the probation officer especially, I try to have the client do that to build trust with the probation officer. So like one time I had a client who had relapsed, and he was court ordered not to be drinking, not to be using drugs. I think his thing was alcohol. And he had relapsed. He wasn't supposed to be drinking, and he did, and we found out about it. And I said to him, I said, that's something that because you've signed this release and because your probation officer, made this agreement with you that you had to come for treatment, you had to sign the release, actually report to him what's going on, that's something that we have to tell your probation officer about. And the person kind of freaked out and thought, oh my gosh, I'm going back to jail. And I couldn't tell him he wasn't going to jail because I didn't know that. That wasn't my decision. But what I said to him was, I think if you tell the probation officer, then it's not going to be me tattling on you. It's going to be you telling him what's going on. And I think that could build trust with him. And fortunately, thank goodness, he talked to the probation officer. The probation officer gave him another chance, said he appreciated him taking responsibility, and that worked out. But I share that just because there can be some awkward self-determination issues there for mandated clients. This wouldn't be terribly different than if you're working with people who have been abusive or neglectful towards their children, and you're mandated to report that to the court. But it's maybe a little bit out of the ordinary for social work. A lot of times we're not sort of forcing our clients' hands that way. And you saw that in the case study night where, we kind of told Hope, hey, if you want to get your job back, you're going to have to let us talk to your boss because it's part of the deal. Okay, one other thing, or a couple other things I wanted to mention about confidentiality. If we don't have that consent form signed from the client, we can't even confirm or deny that the client's participating in treatment. And sometimes this would come up, especially working in residential settings. We get calls and say, hey, I wanted to know if my cousin's there so I can drop off something for him. If I didn't have a release signed, I couldn't even say if the person wasn't there because then I'm confirming that they're not in treatment. Basically, what I had to do is I just had to say I can neither confirm nor deny that the person you're looking for is here. So even that fact that the person's in treatment is privileged information. And the reason we have to do that is that there's stigma associated with addiction. There's stigma with a lot of the things we work with, but there's a lot of stigma associated with addiction. I'll never forget years ago, this was reinforced to me. I was working with a client who was actually a businessman who had a fair amount of money, was fairly well known in the community. And our billing person sent him a bill for his counseling services. And the bill was in one of those envelopes with a clear window in it where his name kind of was on a piece of paper on the bill behind the window. And the bill didn't fit exactly right in the envelope. And so when it went in the mail, the bill slid over. And in that clear window, you could see Name and Center Drug and Alcohol Treatment Services. Or something like that. And so he was just mortified. He came in and said, my postman might know that, he knows other people that I know. It's a small town. And he was really concerned, and I felt really bad. And we actually ended up having to talk to our billing person. We had contracted with a billing person off site. So it wasn't even anybody that worked in our office. We just went through her. She did billing for a lot of small counseling agencies. And we had to say, hey, I think we need to change our envelope system and how we're doing the billing because we violated somebody's confidentiality without meaning to. So it just reinforced to me the stigma associated with addiction. But a lot of times we do need to get that consent because as the last bullet point says here, we often need additional information in order to make a good diagnosis about our client. And we saw that with Hope's situation where we didn't get the whole story at first and we needed to follow up with her, her boss and her husband. So I wanted to talk a little bit about one of the things that often we run into in the assessment process, denial and resistance. And with denial, we're talking about the client taking a stance that the problem doesn't exist, or they might do what we call minimizing the problem, where, I smoke a little bit too much marijuana sometimes, but it's not nearly as severe as my mom and my girlfriend say it is, and it's really not a thing, not a problem. So we're talking about either the person denying the problem exists at all or denying the severity of it. The other thing we and run into a lot is resistance to the treatment process. A lot of times somebody that gets referred for an assessment for substance abuse issues is going to need to enter treatment. You don't get referred for that unless somebody's fairly sure you've got a problem. And so the bulk of people I met with, I did recommend that they enter treatment. I did diagnose them with a substance abuse disorder. And a lot of times the person was very resistant to treatment. And you kind of understand that, right? Entering treatment means I've got to, on some level, admit that I've got a problem. And so that just made it difficult sometimes to get them to engage in the treatment process. And a lot of times there's sort of this, well, I'll come here and I'll sit and I'll do what you say I have to do, but I don't believe I have a problem. I'm just doing this because I don't want to go to jail, or I don't want my wife to kick me out of the house. The other thing that resistance and denial does, and we saw this a little bit in the case study with Hope, is it really inhibits the client's truthfulness during the assessment process. Why would a client who doesn't think they have a problem, doesn't want to be in treatment, thinks it's a big waste of time, feels like people are nagging them, why would they come in and tell us all the gory details? And so the situation in the case study night where Hope tells us one story and says, yeah, I made one bad move, and why am I being nailed to the wall for this? And then we talk to her husband and boss and get a totally different story. Unfortunately, that wasn't too uncommon in my experience, that people would minimize what was going on. They'd give me just the bare minimum of what they could get away with. And a lot of times I'd have to kind of track down the information, or the information would emerge slowly over time. And so a lot of times it was hard to really get a beat on what was going on with people. There's a joke, and it's not a funny joke, but there's sort of some truth to it. I always feel a little bit like this sounds like I'm stereotyping, and I don't want to do that. But in substance abuse treatment settings, there's sort of this old saying that, how do you know when an alcoholic's lying? And the answer, the punchline is, his lips are moving. And the truth is, there seems to be something about substance abuse in general that leads people not to be honest. And that's not saying that they're bad people, but it's almost to the point where it almost feels like a feature of the disorder, where we often know that people have some reason for just not laying all the information out there. One of the things that's really been helpful over the last 10 years or so, and we've talked some about this already in class, we're going to do more with this as the semester goes on, but it's been helpful to have some of these new motivational interviewing approaches to dealing with clients. It used to be that at the end of a session where we knew the person had a substance abuse disorder based on kind of the information they're telling us, we kind of sit them down and say, you are an alcoholic, here's the criteria that you meet, you need treatment, alcoholism is a progressive, chronic, and fatal disease, you're going to die if you don't get help with this. And what we did is we just brought up a whole lot of defensiveness and even anger on people's part, and nobody wants to be told that. And so these new motivational interviewing approaches where we sit down with somebody and say, hey, did you know that you meet these diagnostic criteria for alcoholism? What do you think about that? And how motivated would you be to change this? And what could I do to help you with that? And that's a very truncated version of that process, but this kind of thing, those are the conversations we're trying to have. That seems to do a lot to step around the person's defensiveness and help them to, really be able to look more objectively at the issue. There's some especially difficult assessment scenarios that we run into sometimes. One would be adolescence, and you saw this, I think, with the online discussion that you did last weekend, where we had Chris, right, was the guy that was in the video. I've been trying for a long time to figure out where that video came from. I think somebody was trying to do a documentary, or maybe it was a class project. But it's an interesting documentary because the guy just goes into all these stories about blacking out and throwing up and drinking in class. And you guys picked up on all that when you were doing the diagnostic assessment. And some of you even noticed he was drinking during the video, which is a little odd. But one of the questions I asked you in that discussion was, do you think Chris is an alcoholic, or does he have a substance use disorder? The truth is, it's really hard to know, because we probably all know people that were the party animals at 19, 20 years old who got their act together, and by 30 they were just fine. There's also some people that live the way that he's living in, the way he describes in the video, who get worse and worse and progress into full-blown alcoholism. And one of the problems with adolescents and very young adults is that it's really hard to know. And it's especially hard in our culture that says, oh, your teen years, your early to mid-20s, that's kind of a time to live it up, explore, party, hook up with people. And we don't know is this just kind of them feeling their oats a little bit, or is this really a diagnosable condition? So working with adolescents can be difficult. Another thing can be these DUI, driving under the influence assessments that I mentioned a few minutes ago. They can be really difficult because if the person's only ever been caught for DUI once, we really don't know. Did they just make a bad move one night? Or is this a chronic thing where they've been driving drunk for years and this is the first time they've gotten caught? And there's some public safety related to this. We don't want to put somebody back on the road if we're thinking they might have a problem. But sometimes it's hard to really make an assessment if they haven't gotten in trouble for it before. And so that's another scenario that can be a little bit difficult to figure out sometimes. Finally, I will say I have just run into some very unusual situations when doing these assessments, and sometimes people tell very weird stories. So I'll kind of end with one of the weirdest I ever heard. This is a little bit gross, but not too bad. I had a client come in one time. He worked for a hospital, and his wife really wanted him to come for an assessment, and his boss did. They felt like he was drunk a lot of the time. And the hospital he worked for, he had kind of a low-level job. He was actually a sign maker, so he made signs for the hospital, put up the signs, that kind of thing. It was kind of an unusual job. But he told me this story, and I've kind of gotten different points of view on this over the years. He told me that he had chronic problems with constipation, and that what was happening was that food and liquid was sitting in his bowels and was fermenting, and that this fermentation led to him being drunk. And he said, to be honest with you, I'm sort of my own microbrewery. And I was like, okay, this can't be true. I went and talked to the psychiatrist, who's a medical doctor that we contracted with at the agency where I was working. And the psychiatrist thought about it a while, did some looking, and he said, nope, that can't be true because we require oxygen. Sorry, I couldn't come up with the word there. Oxygen is required for the fermentation process. There wouldn't be oxygen inside somebody's intestinal tract that way. And that kind of confirmed my suspicion. I thought, okay, this guy was just not talking about the truth. And I made some recommendations. I don't think he ever followed through. He wasn't court mandated to come, and I don't think he liked my recommendations, and he just didn't come. And I'm still pretty convinced that what he was telling me wasn't true. But what's really interesting is just this year, we had some friends over on Christmas Eve. One of them is a nurse, and somehow she was telling us crazy stories that she hears at the hospital, and some of the folks she's run into with substance abuse problems. She's done some volunteer work or done an internship someplace where she runs into a lot of people with substance abuse problems. And so we were just sort of telling stories, and I said, well, I've got a good one for you. Here's what somebody told me one time during a drug and alcohol assessment. I related the story I just told you. We all kind of laughed about it, went home. Well, then a day or two later, she sent me a text with a link to an article she had found that actually said that there's a very small percentage of the population that actually does have this problem where food ferments inside of them somehow. So I haven't worked out the whole oxygen thing, how that worked, whether the doctor that told me it wasn't possible was wrong. And I'm still not convinced that this guy was being honest with me. But it was an interesting enough situation that it caused some uncertainty. And what do you do with a story like that? And the truth is, you just get some unusual stories sometimes in this field. And some of it is even, people's perceptions are altered when they're high. They're not making good decisions. They're not always good at relating their own history. And sometimes there's just very confusing situations. So some of these assessments can just be very difficult to conduct. Okay, that's the bulk of what I wanted to talk about tonight. I'm kind of bummed that we weren't able to have class because I think some of this would be a little more interesting in person. We'd be able to talk about it. But at least this way we got a little bit of information out there about assessment. We can follow up with some of this next week. If you have questions or comments about any of that, just sort of save them for the next time we meet in person. Okay, guys, hope everybody's doing well. Hope the rest of the week goes well for you, and I will see you next Tuesday. Bye now.